This is our rehab project for therapeutic exercise over plantar fasciitis. I'm Kaya Carrillo.
And I'm Micah Brooker.
So to introduce you to our patient, his name is Joe. He's 27 years old. He is a construction foreman and a competitive runner. He competes in many marathons and is currently training for one in 8 weeks and wants to know if he'll be fully recovered. Because he's a construction foreman, it requires him to wear steel-toed boots, and that aggravates his symptoms. His symptoms include intense pain in the morning with his first steps of the day, and he rates his worst pain as 7 out of 10. And his symptoms have been present for about 3 weeks.
So plantar fasciitis is inflammation of the plantar fascia at the bottom of the foot. It's usually onset with insidious onset. It can also be chronic due to the low vascularization of the plantar fasciitis. It usually is caused by overuse or repetitive movements, improper footwear, being overweight, having a tight Achilles tendon, and signs and symptoms are typically sharp pain in the heel, and it's often worse, much worse, like with Joe in the first steps of the morning, and then it decreases throughout the day. And gait is also affected due to limited dorsiflexion from pain.
So the surrounding anatomy would be in the lower leg, which includes the gastrocnemius and the soleus, and these muscles insert via the calcaneal tendon into the calcaneus. And like Micah said, when those get tight, it causes increased pronation of the foot, which can also exacerbate his symptoms.
And here's a quick anatomy picture. So the arches of our foot need support, and this is why orthotics are also important in those with plantar fasciitis. And you have the medial and lateral longitudinal arches, and also the transverse arch.
So the bones in the foot include the tarsals, which are the cuboid, navicular, the 3 cuneiforms, the talus, and the calcaneus, and of course the metatarsals and phalanges. So the plantar fascia inserts on the medial tubercle of the calcaneus and runs the length of the foot, which provides support of the arches from the last slide, and provides shock absorption as well.
And there's operative treatments, there's also non-operative treatments available. In operative treatments, the technique used is called open release, and it's just, as it sounds, releasing some of the tension through cutting the plantar fascia. But with surgical intervention, you do have complications like a flattened arch, wound breakdown, infection, and it does take 2 to 3 months to fully return to usual activities as in pre-injury state. With non-operative treatment, there's a reduced risk of complication because there's no open wound. There's a 90% success rate to full recovery, and it can be as simple as changing footwear or including orthotics. And surgery, however, is recommended if the pain persists after 3 months of using conservative treatments.
We chose the conservative treatment for Joe, and this is our rehab plan. With stage 1, the goals listed for pain and swelling and for increasing active range of motion, we included these exercises listed. So this is our tennis ball rolling exercise, where we're going to focus on rolling out the plantar fascia and try to break up some adhesions. Rest is going to be a big thing in this because it is a chronic overuse injury. So we want to decrease weight-bearing activities that are repetitive. We want to assess his footwear and make sure that he's wearing proper footwear that is supporting his arches.
And in stage 2, we're going to build on what we had in stage 1. So we want to further increase range of motion. We also want to maintain his cardiorespiratory fitness. That is important since he's a runner. And we can begin early strengthening. That is important. And in the foot, you have some options as to what you can do to increase strength. as that is one of our goals.
This is a stool stretch exercise for helping a patient increase dorsiflexion. The patient will come forward on the stool and leave the back ankle, leave the heel on the ground as the patient comes forward on the stool. Arch squeezes for increasing isometric strength of the foot intrinsics. The patient will have their foot flat on the ground, and then they will begin by digging their toes in the ground while keeping their heel placed on the ground. So in stage 3, our goals are for increasing range of motion to really solidify his range of motion at this point in his rehab, and increase strength. And at this point, we can begin proprioceptive training as well, and we can also progress to improve his cardiorespiratory fitness.
This is a clock lunge. It can be done many different ways, but for this patient, we're going to do very basic. So we'll start at the number 12, as it would have on a clock. Go to 1 o'clock in a diagonal lunge. Number 3 in a horizontal lunge. 6 in a backwards lunge. We'll do 6 again with our left leg in a backwards lunge. Progress to 9, 11, and end with 12.
This is a single leg deadlift for strengthening of the lower extremity. The patient will have the weight in their contralateral hand and slowly lower into a deadlift, keeping their spine neutral and their leg in line with their body, and then come back up slowly. This is a step up on a Bosu ball, and then we're going to follow that up with a heel raise. So the patient will step up, maintain balance, and then come up on the toe, come back down, and then step off.
Which brings us to stage 4. When we're trying to get him to return to play, we need to increase strength even further. So we've included some plyometrics to further challenge his body and his ability. And we also want to increase his functional and sport-specific activities so that he can fully return to his pre-injury state activities. And we also want to further increase proprioception, as I said, to complete successfully his acts of daily living. And finally, the ultimate goal is being able to return to play without pain, and that's reflected in our goals we have listed. We'll also have our patient perform farmer's carry. He would have heavier weight and include wearing his steel-toe boots and do a normal heel-to-toe walk. This is single leg hop on a Bosu, and we'll have the patient with scissored stance and propel himself on the foot and hop onto the Bosu.
These are the sources that we use to complete our rehab project.
Thank you.